Hello, so today we're going to be looking at seizures and how they progress. So let's start with the definition. So seizure is any type of excessive discharge of neurons in the cerebral cortex. And depending on where the discharge is, you'll get a corresponding symptom. For example, if it's in the motor cortex, you'll get motor symptoms, or if it's related to the face, you'll get symptoms of the face. So you can tell where the excessive discharge is depending on what the outwardly symptoms may be. And classification, this is what I'll begin with. Recently, in 2010, the International League Against Epilepsy did come up with a new classification system. It wasn't too different. They just tried to clarify some of the terminology that was used because it was confused by some physicians. And so what I will do is I'll kind of show you both ways of classification, the previous and the new. And this is because many doctors are still using the old classification system, so you still need to know how they're talking. But again, as you'll see, there's not too much difference. So the first thing, the way that it's classified is either it's partial or general. And this hasn't changed from either classification system. They've kept this. So partial is generally, it's a focal type of lesion, and it stays on one side of the brain. So one hemisphere is only affected, whereas in general, both hemispheres are affected. Under partial, we have simple and complex. These names have been changed. The reason is many physicians seem to be confused about what complex meant. They thought there had to be some specific type of motor movement, which wasn't the case. They've now changed it to partial seizures of a conscious patient and a partial seizure without conscious, and simple and complex. So simple is going to be the patient is conscious the whole time, they're talking to you, and complex, they won't be talking to you, they'll be knocked out. In general, we have four of them. The first one is going to be absence seizure, where the patient just kind of has a blank stare. The next is going to be Tonic-Clonic. This is the classical seizure that we tend to think of. And then after this is going to be myoclonic. Myoclonic is going to be kind of a very quick type of lightning type of burst of muscle contraction, oftentimes confused with a tic. And finally, atonic is when they completely lose all muscle tone and they tend to fall towards the ground. So we'll begin with partial, specifically looking at simple partial. So of course the conscious is intact. They do have pre-ictal phase, and pre-ictal means before the seizure begins. So before the seizure even begins, they get something called an aura. And so the way you want to think of an aura is a premonition that the patient feels he's about to have a seizure. And this is also common with patients who experience migraines. And this aura could be, auditory, so it could be something they hear, it could be visual, it could be some type of smell, and it could even be psychological. So they can have a sudden deja vu. And so depending on the patient, if every patient has a very characteristic aura, it could be different. So they might smell something like smell eggs, or they might see some type of blurring vision or some type of mark, and then they'll know, hey, I'm about to have a seizure. And this is common to most of the classifications there. So after looking at the pre-ictal, we can take a look now at the ictal phase. What tends to happen is they get contractions that can relate to the face, neck, or some of the extremities. And a very specific type is called the versive type. And this is when their head turns in one direction and their eyes go into the same, so they have conjugate eye gaze basically, where the eyes and the head turn in the same direction. Simple partial seizures don't tend to last too long, 10 to 20 seconds, and they're pretty much over it. And post-ictal, so after the seizure, they tend to be okay. There's no symptoms that are lagging behind after that. So let's look at complex. First, we can go over pre-ictal. So first, of course, by definition, there's a loss of conscious, and they tend to have the aura. Sometimes they do, sometimes they don't. And what they also tend to have is something called automatism. So what automatism is some type of complex move, or not complex, but simple movement that you do that you don't think of when you do it. And this is because this tends to affect, when it becomes complex and lose conscious, that means it's not on the outer cerebral cortex, it's kind of gotten subcortical, where you have pre-programmed movements. And so what will happen is the patient will have, exhibit chewing, sometimes they'll have sucking, and even they can do, bicycling, so they can kind of like they're riding a bicycle. And and by the way, automatism can also be part of the ictal phase, so it's kind of both in preictal and ictal phase. Oftentimes, the complex partial seizures can lead to generalized seizures. So you can move on from this, and what happens is the other parts of the brain starts getting involved, and then it becomes the whole brain gets involved, and then suddenly patient is in general seizure. The length is going to be much longer than simple. It lasts 1 to 2 minutes, and in post-ictally, they might have the automatism still remain for a while. That does take some time to clear up. So automatism is found post-ictally. So that is the partial seizures. So we have simple, where they have consciousness and it lasts about 10 to 20 seconds, and then we have complex where they become unconscious and it lasts 1 to 2 minutes. So now we'll go over to general, and again, just to kind of recap, there's absence, Tonic-Clonic, Myoclonic, and Atonic. And absence does have another name called petit mal, and Tonic-Clonic is often called grand mal seizure. So let's go to absence first. Generally, this occurs in patients who are greater than 5 years old, and it's a slight predilection for girls over boys. There is no real preictal symptoms. What happens is, they just they're kind of doing something, and then they jump straight into ictal state, and what they do is they just kind of stare into space. You do have a sudden cessation of motor activity, and what happens is they can also have they have cessation of motor activity, so they stop doing whatever they're doing, but that doesn't mean they lose tone necessarily. And there is flickering of the eyes oftentimes, and these symptoms tend to last less than 30 seconds, so not too long to be worried. Their posture is okay, so they don't tend to fall. However, their head does tend to move slightly toward one side or another. Okay, 1 second. So tends to move toward slightly. And finally, a very characteristic EEG finding is that it has a 3 Hz spike, and so this is mentioned oftentimes, so it's good to know a 3 Hz spike is associated with absence. So let's talk about Tonic-Clonic or grand mal. Pre-ictally, depending on what the etiology is, can have different types of symptoms. The first one is they can have a fever. This can be either with febrile convulsion or meningitis. There could be an aura. And this aura is important because it does help understand if there's some, especially if it's a focal aura, you can see where the location of the lesion may be. And finally, fever if it's a child. Okay, so ictally, what can happen? Well, first of all, they do have a loss of conscious. Oftentimes, they might cry or yell out as soon as it happens. And usually the first thing that does happen is their eyeballs roll backwards, and then they have the classic muscle contractions that's associated with tonic-clonic. Also, there is sometimes they can become incontinent. They lose bladder function and they urinate on themselves. Post-ictally, it's the whole ordeal tends to be pretty difficult on the body, very stressful. So afterwards, they tend to be very tired. They might even be in a semi-comatose state, and oftentimes the patient just wants to sleep afterwards, anywhere from 30 minutes to 2 hours. So they're very, very tired from the ordeal. There's also something called Todd's paralysis that is associated with the post-ictal state, and this is generally truncal ataxia, so they can't really get their trunk moving well. They have decreased deep tendon reflexes, and there's even a moment of decreased cognition where they can't understand what's going on. And besides that, you also can get vomiting and headache associated with the post-ictal phase of the tonic-clonic seizures. Okay, so now we can move. So we did tonic-clonic. We can move on to myoclonic. Myoclonic is when there is a symmetric contraction of the body, and there's a loss of body tone as well. And this is associated with a few syndromes. So we'll go over some of those syndromes here. First of all is going to be the Juvenile Myoclonic Epilepsy, and so this is going to be, they have myoclonic seizures starting at the teenage age. The other one is going to be a progressive form of myoclonic epilepsy, and this progressive form is associated with inability to walk and some difficulties in speaking as well. Beside this, there is myoclonic epilepsy with red rag fibers, also known as MRF. MRF is a mitochondrial disease where it affects the muscles, and so it's not necessarily a brain disease, but it can affect the brain because the mitochondria is important there as well. So it's a mitochondrial disease overall. The next one is going to be Lennox-Gastaut. Lennox-Gastaut is also known as epileptic encephalopathy, and so it is associated with decreased intelligence, and this is a more severe form that doesn't respond too well to medication. However, the other ones do respond very well to medication. These tend to last 1 to 2 seconds and is often confused with a tic. The final one, which is also the easiest, is atonic. So atonic is basically a sudden loss of muscle tone. So the patient is walking around doing something and a sudden loss of muscle tone, they come crashing to the floor. And as you can imagine, this is very often confused with fainting. So the patient believes he's fainted, but he actually just had a seizure. So this is overall what we've covered here. Again, it's partial and general. In partial, you have simple, which is associated with consciousness and lasts about 10 to 20 seconds. In complex is unconsciousness. There's automatism, and it lasts about 1 to 2 seconds. And so that wraps up partial right there. In general, we have the 4 types. First is going to be absence, which is going to be staring into space, and EEG. And actually, there's a typical drug which is used for this. Ethosuximide is the drug of choice for that. Tonic-Clonic, you got the sudden muscle contractions and the post-ictal state, which is very severe on the patient. Myoclonic is associated with these congenital conditions, and finally you have atonic, which is fainting. Okay, so after we're done with that, we can talk about the etiology. Basically, any insult to the brain can cause seizures, so that's something to remember. A good classification system that I use doesn't cover all of them, but does cover most of them. It's called vitamin P. So the V stands for vascular insults, such as stroke or AVN. There's also infections, so that's probably why you want to check CBC for these patients. And also another I could be inherited conditions, especially in the pediatric population. T is for trauma, that can definitely cause it. A for Alzheimer's is associated with it. Then you can also have metabolic disorders, any type of low calcium, sodium, magnesium, or glucose. And the glycogen storage diseases any storage disease can be associated with it. I, idiopathic, a lot of them they don't really know why. Neoplasms can cause it, and there's also neurocutaneous disorders such as Sturge-Weber, tuberous sclerosis, neurofibromatosis can also cause it. And psychogenic. Psychogenic generally is a diagnosis of exclusion, so if you don't know what it is, we just say psychogenic. Now, depending on the age group, there are some extra common causes, especially in the young infants. Febrile seizures are very, very common, as well as juvenile myoclonic. We also talk about MRF, and that's going to be more in the pediatric population. And finally, Lennox-Gastaut as well. And these were all the congenital causes of especially myoclonic seizures. In adults, alcohol withdrawal is also a common cause, and as well as strokes and tumors. Another one that you can also say is a cause is patients who are on treatment. If they're not compliant with the drugs they're taking, that can sometimes initiate a seizure. Okay, so let's talk about kind of the workup, the investigations, and how you would diagnose it. The important thing that you want to do is you want to get a good history. The first thing that you want to look at is the aura. That can help kind of figure out where in the brain is affected. And then you want to go pre-ictal, ictal, and post-ictal. So you want to ask these to people who were maybe standing around who witnessed it, and this can help kind of rule out and maybe figure out what's going on. So that's very, very important to ask those questions. Now, to diagnose epilepsy, it does require 2 seizures, so 1 seizure is not enough. And generally what you also need to do in order to diagnose it is you need to do an EEG. Depending on where it is in the brain, they get very characteristic findings. And generally this is done by neurologists and interpreted by neurologists. You also might want to do a CT and MRI, especially if they're over 30 years old, to rule out tumor. And you also want to rule out any type of focal abnormality that you may find. Besides that, there are some lab work you might want to do, sodium, calcium, magnesium, and glucose. Again, these are associated with seizures. How would you manage the patient? So management, if it's a first seizure, we need to try to look for common causes. So you want to say, well, is this febrile, especially if it's in an infant? So it could just have been a febrile case, or it could have been some acute onset, maybe due to alcohol withdrawal, drugs, anything like that. Now, recurrence is going to be a problem, up to 24% recurrence rate. And so generally, when there's a first seizure, you don't give them any anti-epileptic drugs. But what you do want to do is, because there is a 24% recurrent, you do want to educate the patient what to do, especially if it's a child. So the first thing is common misconception. You don't want them to swallow their tongue, but that's actually not a good idea. You don't want to put anything in the mouth because that can lead to further trauma. You do want to try and remove or loosen up any tight clothing because that can constrict certain areas and then cause damage there. Remove any sharp objects nearby or heavy objects that might fall on them, and you do want to watch their head. You want to try to cushion their head, put a pillow under it or around it to protect their head so they don't get any type of head trauma. Now, if the whole incident lasts less than 5 minutes, then do nothing. Just kind of tell them it's not a big deal. Just go to a neurologist and get it taken care of. However, if it lasts greater than 5 minutes, you do want to give them rectal diazepam, especially if it's a child, and you want to go to ER. And the things that you're worried about is oftentimes if it lasts less than 5 minutes, greater than 5 minutes, it can be status epilepticus. So you want to go to ER as soon as possible. And so overall, after first seizure, you do not want to give anti-epileptic drugs. Now, what if it recurs? If it recurs, you're probably going to refer to a neurologist who will do an EEG, and based on those findings and the type of seizure he had, he's going to give different type of anti-epileptic drugs. There's so many anti-epileptic drugs, it's not really fair to just kind of say, give this one or give that one, and it's a lot of empirical evidence has been done. So pretty much the neurologist will figure out which drug to give. But the general policy they use is they'll start with one drug, and their preference is to just use one drug as much as possible. Now, if the patient gets better with that one drug, good. So that they'll continue using that drug as long as it's working. So that's good. However, if it works partially, so if it just lowers the amount or the recurrence or the severity, then what you'll do is you'll try to increase the dosage, or you can add another drug. And if it doesn't have any effect at all, then what you'll do is you just try another drug. So it's kind of guess and check type of thing. Now, here's the thing: there does need to be a balance that the neurologist is always trying to make, and the balance is the toxicity of the drug versus the seizures. So you do need to, they are trying to limit the dosage and the type of drug they use depending on what type of seizures they're having. There are some general principles that you can use. And I kind of alluded to this earlier. Absent seizures, you can use ethosuximide. That's specifically for that. And there's also good to know that there are some broad spectrum medications that you can use, which work for pretty much all of the seizures except for absent seizures. The first being valproate, which actually does work for absence as well. Levetiracetam, which is also known as Keppra. Lamotrigine is also broad spectrum. And finally, felbamate. So these can work for all of them in general. Withdrawal, you are trying to get them off the drug because, again, there are toxicities. And generally what you do is if they have 2 years of seizure-free, then you will try to get them off the drug, but you need to taper the dosage. because you don't want to have because a lot of times when they get off the drug suddenly, they can have a sudden seizure, and it could be very, very severe. When they get off the drug, there is about 30 to 40% chance of recurrence, so you do still need to monitor them. Now, after trying the drugs, if that doesn't work, if it's refractory to medical treatment, there are other treatments available. The first is going to be ketogenic diet. So this, no one really knows why this helps, but it does tend to work. And what you try to do is you try to induce the body to produce ketones, and that helps. So no one really knows why. And the other one is going to be vagus nerve stimulation, and this is when you activate the vagus nerve, and that goes up and activates the brain somehow, and that tends to help. And finally, if nothing else works, there are some surgeries that can be done. The first one is corpus callosum, where you cut the corpus callosum, and the two halves of the brain can't speak with each other, and so that's generally used for myoclonic. You can also do lobectomy, where you take out a particular lobe, and you can do a hemispherectomy, where you take out half the brain. And so as you can tell, these are very, very serious surgeries with a lot of complications, and so unless it's really, really bad, you don't want to do these, and obviously a neurosurgeon would take up the case anyways. And finally, if there is a tumor, you can do surgery to remove a focal tumor. So thanks for watching this video. I hope you enjoyed it, and I hope to see you in the next video. Thanks.